Good afternoon. I am Dr. Nazrul Islam from Bangladesh. I am thankful to 9th World Glaucoma E-Congress for the opportunity. While in next 5 minutes, I shall talk in favor of primary trabeculectomy for the management of neovascular glaucoma. I do not have any financial disclosure. If we look to the very recent study on primary TVT published in Ophthalmology by Stephen G. Getty and his team, treatment outcomes in the primary tube versus trabeculectomy study after 3 years of follow-up. And they found and concluded that trabeculectomy with MMC achieved a lower IOP with use of fewer glaucoma medications compared with tube shunt surgery after 3 years of follow-up. This is a world-famous study. It is conclusive that primary trabeculectomy is the choice of surgery in the neovascular glaucoma. We know 81% of cause of NVG is the CRVO, BRVO, PDR, or the carotid artery occlusion. And you can treat the cause, then of course it can easily be prevented, the angle closure glaucoma to need the surgery. Whenever you need surgery, of course you need to do comprehensive management. Other than surgery, you have to treat with steroids, cycloplegic agents, IOP lowering agents, pan-retinal photocoagulation, focal laser photocoagulation, anti-VEGF agents like bevacizumab, ranibizumab, along with the surgery. And when this surgery comes, it is the flowchart showing that trabeculectomy with mitomasis C is the primary surgery for the treatment of neovascular glaucoma. Of course, if the trabeculectomy fails, then we can definitely go for the tube shunt surgery. Yuji Takihara and his group showed that if you use the bevacizumab preoperatively and do the trabeculectomy with mitomasis C, the outcome becomes much more improved. In another study, Ayman A. Alkabas and et al. Found if you use the pan-retinal photocoagulation and also intravitreal bevacizumab along with trabeculectomy with mitomasis C, the results is significantly improved for the control of IOP for longer time. Regarding the trabeculectomy, in the neovascular glaucoma, you have to do a modified trabeculectomy. Like you have to use the higher concentration of mitomasis C, longer exposure time, and of course, you can make a larger flap, a larger block dissection, so that fibrosis will be less and success will be higher. Saito et al. And Takihara et al. Found if you do not use the anti-VEGF agents or the laser, only Trab with MMC can give you 62% success rate. But if you use the laser and anti-VEGF, the success improves up to 95%. It's very important. Now, if we compare the Trab and tube, the tube needs more conjunctival dissection, more extensive surgery, more expensive surgery, and not affordable by most patients in the developing country. On the other hand, trabeculectomy is less expensive, more successful in IOP lowering, less vision-threatening complications, as already we have found in the primary TVT study. So, in conclusion, I will say that neovascular glaucoma is a potentially blinding disease, but if you can manage with preoperative anti-VEGF, laser, and modified trabeculectomy, the success becomes more than 95%. So, Dr. Xiulan Zhang, I think she will be now convinced that primary trabeculectomy is the surgical treatment of choice in the neovascular glaucoma, not the tube shunt. Thank you so much.